Good afternoon, everybody. I'd like to welcome everyone to this month's Azalea Health Industry Webinar. Today we're going to be sharing a time of service collections initiative that was implemented at Union General Hospital. My name is Rhea Patel. I'm a health IT analyst here at Azalea, and I'll be your moderator today. I'd like to start out with a couple of housekeeping items. First of all, this webinar is going to be recorded, and the video recording, presentation, as well as all of the handouts that are available during this presentation will be emailed to all attendees later this afternoon, as well as made available on our website. Please know that we will reserve about 15 to 20 minutes of questions at the end. If you want to submit any questions for our panelists to answer, please submit them using the question section on your webinar panel in the bottom right-hand corner of your screen. We have several useful documents and spreadsheets that our panelists have been very generous enough to share. You can download these handouts as well as a copy of the slides on our website after the webinar, and they will be emailed to all attendees later this afternoon. A few of these handouts are also available in the lower right-hand corner of your screen on the webinar control panel right under the section labeled Handouts. And now to introduce our panelists. Today we have Jay Mary with us today. He's going to be discussing the Time of Service Collections Initiative that was implemented at Union General Hospital, where Jay serves as the Director of Revenue Cycle. Union General Hospital is an award-winning 45-bed nonprofit facility in Blairsville, Georgia. The system has a number of rural health clinics and physician practices, as well as a sister hospital here in North Georgia as well. Union General is an Azalea RCM and EHR customer, and they have really exceeded in providing high-quality care to their community. I'll let Jay speak about his background a little bit more, but to acknowledge his outstanding accomplishments, he's the recent recipient of the Hometown Health 2016 Revenue Cycle Leader of the Year Award. Jay was selected for outstanding leadership in sharing best practices for his commitment to excellence, employee education, business partner endorsement, and revenue cycle improvement. So without further ado, I'd like to turn it over to Jay.
Thanks so much, Rhea. I really appreciate that, that stellar introduction. Well, good afternoon, everyone. My name is Jay Mary, as Rhea indicated, and as she said, the Director of Revenue Cycle for Union General Hospital, and we're up in Blairsville, Georgia, and are a very, very strong business partner of Azalea Health, and I do appreciate the opportunity to kind of give you guys an overview as to our Time of Service Collections initiative that we've recently implemented, and they're in the middle of rolling out. So thank you so much for this opportunity. Kind of give you you guys a real quick background overview of myself. I've been in the industry for, I guess, about 13 years now, give or take. I really started primarily in the ambulatory arena. So I was a project manager for an EHR out in Carrollton, Greenway Medical. Went and implemented next-gen EHR for both Piedmont Heart and also a facility up in northern Indiana for a number of years. I recently crossed over to the acute care world about 3 years ago, and have really been in the mix of things here at Union General. As she indicated, I oversee revenue cycle operations for both Union General and Chautauqua Regional. Union General is a 45-bed PPS facility, and Chautauqua Regional is a 25-bed critical access hospital. In terms of volumes, Union General, we look at annualized about 20,000 ER visits a month. From an outpatient standpoint, we're at about 50,000. Chautauqua Regional is a 25-bed critical access facility, so they obviously have smaller volumes. So it's kind of an overview as to who I am and what I oversee. I oversee patient access, billing, HIM, oversee the business office, and case management here at Union General. So quite a lot of things going on in my world, but I did want to share with you guys it's an initiative that we implemented here as of about 5 months ago now, and it's really started to pick up, and we've really seen some successes, which I think can be leveraged in the ambulatory arena. So the first slide there, obviously, gives you an overview of what we've done. Context at Union General, the culture here is really what drove a lot of our collections. So small town. Everyone knows each other, and I think it's probably a commonality in the ambulatory setting. I know I saw that a lot when I was with Greenway and also at Piedmont. People are really expected historically not to have to pay up front for a service they receive. So They expected third-party payers to step in and pick up a sizable portion of their balance. And again, in small towns, people know each other. Therefore, for the most part, the organization expected that those people would pay any small out-of-pocket monies due. We had a large Medicare and commercial payer mix, obviously, in a small percent of patient cost sharing as a result of those. Administration here had really taken a position of wanting us to limit refunds to patients. So it was really a patient dissatisfier when we charged a patient or we asked for money for a copay or a deductible, and then later we adjudicated and found out that the amount was not correct and there was a refund that was in place or that was due. It was really determined that was a patient dissatisfier that was escalated up to administration. And so we really had administrative, direction not to do that. So all of those things really built into a culture of sort of complacency as it relates to collections, and that did not do a lot for the organization as it relates to cash flow moving forward in this new era that we're now in. We also had a limited tool set. So as I indicated on the slide there, at Union General, we early on had no eligibility verification service whatsoever. Later there was a basic implementation, so we were told if the patient had active coverage or if it was inactive, termed or not, but there was limited response details in terms of patient eligibility and or out-of-pocket amounts, co-insurances, etc. that a comprehensive response returns. KPI management, there was none. Previous management really didn't focus on KPIs as a whole, and so as an organization, we didn't know in that perspective where we were or where we were going in terms of collections, so there was virtually none that were tracked. We did have some systems that made it difficult to calculate those, and so certainly it wasn't just a personnel issue or a culture issue, but we had a systems issue as it relates to facilitating calculation of those KPIs. It was very difficult in the past to do that. We use an acute system here called McKesson Paragon, and McKesson Paragon is notoriously difficult for providing accurate and dynamic financial reports. No tracking of collections as it relates to the presentation here. Very difficult to track those collections that were made, time of service, who took them, and track those back to the department. So all of that really just built into, again, a culture of complacency. We historically had been very retrospective, as it relates to our collections attempts for aforementioned reasons. We found it worked out well for us, again, as we allowed the claim to adjudicate. Patient statements were generated accordingly. On self-pay patients, we did take down payments, and we've always had a financial assistance policy in place as required by the IRS, but again, most of our collections was done retrospectively, very small amount time of service. Just shifting payment models, as you guys well know, models due to changes in the industry with the ACA, we've got many more high deductible plans out there that drive our need to collect time of service, and so that led up to kind of pushing this initiative internally. Obviously, I myself have always been a large proponent of trying to collect up front, but I think this shifting model is really driving the industry forward, and has been so at Union General. It also is the case, as you guys well know, in the ambulatory arena, so I think some of these strategies can help regardless of the setting. Next slide. So as an organization, we met as a leadership team, and we talked about ways to change this culture and to really implement this change. And the team that I've compiled looked at different settings that we could begin to implement this. And so in an acute care world, there's several areas where we engage and register patients. We have an opportunity to collect up front. Ultimately, we ended up settling on the ER, and there was a variety of reasons for this. Starting point was essentially zero. Again, the culture was the primary reason, but also I think due to the mass volume that we had there, we had zero collections. And so I think for the entire, and I'll give some numbers a little later, but for the entire fiscal year of 15, we collected just over $4,000 down there, and that's with about 20,000 visits for that particular period. We also decided that, so therefore, as it relates to the starting point, it would be easier for us to assess any success of a program. It was also a controlled environment. It's easier to evaluate changes when you have a controlled environment, such as what we have in the ER. An easy place to evaluate the success and or the applicability of policies and procedures, and to evaluate success of any changes that we would make as a result of that. We have a limited service offering there. Obviously, emergency care is a single limited service. In those cases, mostly copays and deposits only are applicable. Some of our other peers do also estimate or collect on actual services rendered. The model that we have currently does not allow us to code and charge timely enough to do that. So we really just focus in our scope on copays and deposits only, but we thought it was a good environment for that. I mentioned high patient volume, more opportunity for engagement. We know that with about 20,000 registrations down there, there's a high opportunity for our registrars to engage and to refine their processes accordingly. Limited staff. We also have limited staff. We have about half a dozen registrars that routinely circulate down there across 3 shifts. So we knew that it would be fairly easy for us to train and accurately share information with those registrars in a way that we feel confident. I mentioned earlier we also considered outpatient. A lot of the industry experts think that outpatient is the right area for us. We decided against that, really because of we felt like the ER was a more appropriate place given the aforementioned reason. But we did consider outpatient, and we will go back to that once we get once we get our systems and processes refined. Historical performance for fiscal 2016. As of today, these were as of, actually I take that back, it's the end of November. Time of service collections as a percent of net revenue is a primary KPI for tracking your time of service. For us, as you see there, we were less than a little more than 0.04%. Shattuck was a little bit better than that at 0.08%. Industry benchmarks that I indicated there, top quartile is a little over 1%. National average is 0.8%, and of course the best. We got these numbers from HFMA and the Revenue Cycle Academy. I think MGMA also has standards for or thresholds for these KPIs for the ambulatory arena. Average collections based on volumes, I mentioned about 20,000 during the period. We averaged about 21 cents a registration at Union and about 35 cents a registration at Shattuck. So quite a good ways to go. As you can tell, we weren't doing very well initially. So next slide.
So we're actually going to ask the audience a polling question right here. So in a couple of seconds across your screen, you should see a question, and if you could take a couple of seconds to answer it. So the question is, do you currently track time of service collections at your practice? All right, we're going to close the poll and share the results. So it seems about 66% of our audience answered yes, 23% answered no, and 11% answered I don't know. Jay, do these results seem kind of like what you expected?
Yeah, absolutely. You know, I think that's about what I expected. At Union, we certainly were in the no category. You know, I can also vouch for our practices that use Azalea. They were also in the no category. So you know, I think across the industry we see that changing, and so I'm happy to see that 66%. But as an organization, we certainly weren't in that number.
All right, and we'll go back to the presentation now.
So I took a screen print of a poll that was taken by the Revenue Cycle Academy, and so as of the end of 15. You see the numbers there. Average annual point of service collections in the ER. We certainly are under 200 beds, even as a system whole. The average there is about $11,000 a month. We were well below that, and so as I mentioned before, with the 21 cents per registration, we were at about $4,000 a year. And so I wanted to just include that to show kind of the how far below I think our peers and in the industry we were, and how far we have to go. but it does show you kind of the distribution regarding organizations based on bed size. All hospitals is about pushing $500,000 a year, and I think we've got a good ways to go as an organization. But that does show kind of how I think this initiative is driving collections in the industry. Next slide. So some challenges that we had as an organization, I want to bring out because I know that you guys may experience some of these same challenges, but policy and procedure development, we didn't have any here. We had quite a few policies and procedures in the business office that were related to financial assistance, sliding payment scales, etc. Some of the policy and procedures that drove how we did business with certain vendors, but little as it relates to collections, specifically time of service collections. We had basically zero there, and so nothing on paper. So we had to get together as a team and start those from scratch. I did have some templates that I had brought from my previous life that I'd worked with a vendor, a consultant rather, and so we had some stuff that I knew represented best practice, but nothing as it relates to anything on the table. Cash control, you guys well know that when cash is being exchanged, at the encounter level, in operations, that you have to have tight control processes and procedures that safeguard that cash. And we had nothing here because, again, nothing was shared. We also developed those. I did have some experience with those from my previous life, and so that was something that we technically weren't starting from zero, but there was nothing on the table at Union thus far. We knew it was going to be hard in the ER because of obviously the patient volumes, high volume traffic, and there's a significant potential for error and loss there. We had to buy a safe, we had to buy cash drawers, so everything was purchased to support this initiative, from the onset. We wanted controls as it relates to cash control to be set up and structured very much like a bank or a retail setting. Across the industry, those processes are very similar, and they need to be airtight and such that it could be managed on an ongoing daily basis by administration. EMTALA regulation compliance. In an ER setting, EMTALA guides what we can and cannot do as it relates to patient treatment and initiating discussions regarding payment. We had to maintain those regulations. Specifically, a medical screening exam had to be done and complete before discussions regarding financials could commence. So we had to maintain that. Historically, we had done a good job engaging insurance information discussions with patients in accordance with EMTALA, but we had to maintain that with this initiative as well. Clinical staff cooperation. We had a huge problem in our ER, and I don't think it's uncommon, but very polarizing as it relates to the culture there with the clinicians. Clinicians think they think they need to treat patients. Anything that has to do with registration, collections, insurance information was specifically an administrative duty. So we had a problem there, and we had to see a culture shift in order, I think, to make this successful. We also had an issue with discharges prior to full registration. What I wanted to do was kind of address that issue along with this initiative. And as we got clinical buy-in, I knew that it would help solve that problem. We didn't use what they call computers on wheels. A lot of ERs will use mobile computers to try and facilitate registration and payment posting. We didn't use that at Union. We had some issues with scanning and I think limitation as it relates to hardware and technology that led us away from that. I did maintain that with this new initiative, but we have a process that I think is working without the cows. Physician indicated that the completion of the medical screening exam in compliance with EMTALA was communicated in a variety of but ways that were not consistent. And so having the registrars observe the differing methods and the ways the physicians communicated that was very difficult. We had to get their buy-in so that we had some standardization with respect to that communication. They just didn't know when they could present to the patient to engage in those collections discussions. So that was difficult as well. HIPAA, patient privacy, was most important. We had to maintain that. We do not have full private rooms in all of our ER in all the ER areas. We have some semi-private as well, and so we had to develop a process that would help maintain that patient privacy. As it relates to initiatives, one of the successful components of our program was the implementation of an initiative program to pay registrars for some of their success in regards to collections. We knew that this was going to be required because of the additional tasks that we were laying on them in addition to everything else that they were doing. So in an acute care setting, the registration process is fairly onerous. We have some other processes as it relates to enrollment in our health information exchange. And so there's a lot of things going on, and we knew this task would be just an additional burden. So the incentive program was something that we also had to carve out and was going to be a challenge for this success of this program too. Next slide. I included this as best practice for ER collections. It's just from the Revenue Cycle Academy and talks very high level about sort of the standard practices around collections. In the standard practice row there, they're really just discussing how most of the clinicians believe that collections is not something that's important to the success of the organization as it relates to treating patients, and how that is not where the industry is going. The two different tactical approaches, or the three tactical approaches, give an option for collecting at bedside, which is the center column. They give an option for collecting at a discharge area or a quote checkout area, which is the leftmost column, and then they just call out the importance of engaging ER clinicians to make your program successful. So just from the industry, these are some successful benchmarks that have been identified across the spectrum, and we knew that we had to implement some component of this in our plan to make it successful. Development. The way that we approached creation of this program was really by instilling a focus group. So I pulled together a team of high-level leaders: patient access director, registration team lead, business office manager, billing manager, and ER nurse manager. We also had input from the ER physician as it relates to creating all of the components of this program, such as policies and procedures, which I've called there. I mentioned before, I had a basis from a previous assignment, which I knew the policies and procedures were based on best practice, and so we really began with that sort of as a subset, and we went from there. So they were heavily customized, but we weren't starting from ground zero. I discussed cash control. That was very highly discussed in our team meetings, because everyone at the table understood the importance of controlling that cash and ensuring that it was secure and wasn't walking out the door throughout the course of the shift or during shift changeover. We talked about scripting. You guys well know that leaders, for the most part, do a better job, I think, quoting or identifying how we want our staff engaging in discussions with patients as they question the need for collections. We were very careful at crafting those scripts, and we bounced those off of frontline employees as well to get their input. We used Revenue Cycle Academy as a source for that, and as I mentioned before, they sort of pull from the industry across the spectrum of hospitals, and so we had that input as well. We wanted the registrars to know what to say and when and how to say it, and for there to be no question regarding how to handle the situation that they would be presented with respect to collecting. Our workflow, discussed very briefly about, actually, let me go back. The job aids, we were very specific about creating job aids. We used McKesson Paragon, as I discussed, and we included screenshots, training. We included best practice standards, and we also we created competencies for our registrar. So as we developed this training plan, competencies were critical. So every registrar, as they were trained, had to sign off on the competency, and so there was no question as to whether or not they understood where we stood as an organization. Workflows. I mentioned CALS before. We decided not to move forward with purchasing additional devices or hardware for that. What we ended up doing was developing a two-tiered approach with respect to collections because of the nature of the ER, with some rooms being private, some semi-private. We engaged patients that were in private rooms at the bedside and did full registrations on those, and then we engaged patients that were in semi-private rooms in a checkout area that was designated in the ER. So we sort of split the difference between those. So it ended up working out quite nicely for us in that respect. It also maintained EMTALA compliance. Again, we wanted to be sure that we were not overstepping our bounds as it relates to discussing financials prior to a medical screening exam. That was maintained in the plan. We incorporated it with full registration. We have a tracking board system in our ER, and it had not been functioning as it was designed early on. We did engage the vendor and made some changes that really helped the clinicians know and the registrars know when it was safe to approach the patient and execute a full registration and also do engage in the financial discussions regarding their out-of-pocket amount. So we did use some technology in that area, and that seemed to help out quite nicely. We also have circumstances where we have got a fast track program there and early discharges. So if there was ever an instance where the patient needed to be discharged prior to the registrar coming around, we have someone staffed in that checkout room to engage in those in a way that was compliant and it was private, and we could collect on them as well. Next slide. Some tools that we developed as a team that were critical in our success. WebPay, we used RelayHealth WebPay as our credit card processor. There was some technology changes as it relates to that WebPay, which allows us to integrate our eligibility response into that WebPay toolbar. So they work from a single screen to actually post the credit card transaction and observe those details via the eligibility response. And so it's a one-stop shop, if you will, for our registrars. It's called the RevRunner toolbars, which I've called out there. We also have in the hopper as an organization an estimator solution, which is also a RelayHealth product, which will allow us in a different setting, and specifically in outpatient, some of our other ancillary departments, to accurately engage the patients prior regarding the expected out-of-pocket amount given the services rendered. So we'll have financial counselors that'll be teeing that up and presenting that to our registrar so we can collect subsequently. That'll be a sort of a phase 2, and that'll be pending the implementation of this system, which is for us coming into around about the end of December this year. I mentioned policies and procedures. Policies and procedures, we've got about 9, and I did include those and provide those for you guys. If you wanted to use them, they're available to you. We worked as a team to create those. Again, I mentioned they were instrumental in our success. Just for the top ones there, the point of service collections, we've got a cash drawer policy procedure, WebPay reconciliation. So there's a whole host of those. I mentioned about 9 that we've got available that were critical in our success. I mentioned competencies, and so they had to sign off on competencies, having reviewed these and their understanding of them as well. SciSense is a business intelligence tool that we as an organization opted to purchase about a year, 18 months ago now. We had such difficulty, as I mentioned before, with Paragon and the reporting that we had to look outside the box for a way to get physical services accurate, dynamic, and detailed information on a regular basis. We moved forward with this BI tool. I've been able to leverage that for really success to help us as an organization in this initiative and in others in the revenue cycle realm. This business intelligence tool really allows us to accurately track key KPIs. It allows us to track time of service collections on a dynamic, ongoing basis to the registrar level. What I do as an administrator is I can export that, and I'll provide the collection details to payroll, which of course disperses based on the number of amounts collected by registrar. So SciSense really operationalizes management of this program and will be used moving forward as a whole. But I wanted to throw that in there as a tool. I realize being in your shoes that calculating KPIs without a dynamic tool is a difficult thing to do. Before, I used Excel and Access, and this BI tool really helps us as a team, and it's critical to the success of this program. So I didn't want to include that as a tool there. So next slide. I gave you just a really quick snapshot of a few dashboards that we use. The collections analysis dashboard there is one that was created. It gives me net collection ratio, which is going to be your upper leftmost widget there, 67.4%. You guys know that ratio being on the revenue cycle end of things, payments minus refunds divided by charges minus adjustments. But that gives us the system sort of a generalized indication of how well we're collecting monies that are owed the organization. It's filterable by department and by service line. All of these widgets will just simply respond when I employ those filters. Time of service collection ratio, simply your time of service payments divided by net revenue, is something that is calculated based on the service line and also on a daily basis. It gives trends. Those trends there with the regression line is the fiscal year to date, and it updates on a monthly basis. The next slide, I think, shows payments and adjustments by month and how those values contribute to the different ratios. Next slide. There we go. So that bar graph there, or column graph at the top, is showing me that payments and adjustments, and then unqualified adjustments. The pie chart, insurance by payer, patient payments by type for the period in question. So however I've got the dashboard filtered, and the screenshot is the display that it's providing me there. You see there patient payments by type. It's about 50-50 as it relates to check and online credit card payments. The difference is cash and money order, obviously, but that lets me see as an administrator how we're collecting there. Next slide. Finally, we've got patient payments by month trending, and a detail, and it's got insurance payments there as well, trended out with regression. You see the component of the contribution of time of service payments to both graphs. I didn't include it on this particular display, but there's also a detailed unqualified adjustment by account that we can export and look at for investigation. Obviously, your net collection ratio is adversely adjusted by your unqualified adjustments, and so that lets us drill into the cause of those that are ongoing. So next slide. Time of service payment, I mentioned this very briefly. This is what I'm using on a monthly basis to provide my incentive payments to my registrars. Payments by method, the topmost pie chart there, you've got payments by month, and so you can look, really the first month that we started was July, and it's been going up ever since. We had a little bit of a down month in November, but October was extraordinarily high. It was at 12,754, which is where the screen print came from. Registrar, you can't see it, I know it's small, but the bar chart there, or a column graph, is showing you the collections by registrar, and so we've got a particular registrar there who's blowing everyone else out of the water, and of course she's incentivized, but it shows me that. We've got payments by patient type there. 44% of all time of service payments collected during this period were ER. The rest are broken out there accordingly. I can export this information I mentioned prior for disbursement. There's a detail to this, and so all of that easily allows me to easily calculate these incentives for these registrars moving forward and look at areas that we can improve. I mentioned the incentive plan. This plan again was developed by the team. It was also we got feedback from other facilities, other third parties such as Revenue Cycle Academy and HFMA. What I really wanted to do as a director was look at what it was costing us to collect on the back end. We do the primary collections for us. We have an extended business office center that we use, and so I know approximately what the cost was for that collections. And so what our intent was to transfer that cost up front and to, in essence, pay the same out to our registrars, and therefore improving the market or the economy locally rather than paying an out-of-state vendor. So that was what we looked at. You look at the breakout there, graduated by for the actual collections for self-pay and insurance. We offer a 10-day window, so if a registrar engages for a patient early on and it takes that patient, a week or so to remember they had that conversation, and they call the business office and make a payment. That registrar is still being credited for that collection. We pay out monthly in the following pay period. So right now, our next payday rather is on Friday, and so the registrars will receive payment for their November collections in that period. Next slide.
All right, we have another polling question for the audience. So the question is, does your practice or organization incentivize collections currently? You could take a couple of seconds to answer this poll. All right, we're going to close the poll now and share the results. So it seems about 70% of the audience said no, they are not currently incentivizing collections, and about 20% said yes, 9% said that they don't know. Jay, do you want to comment on these results?
Yeah, those results are, I don't think surprising, because we didn't do that here, but again, we didn't collect here either. I think, as an industry, at least on the acute care side, a lot of hospitals are moving to that. I can't specifically speak to the ambulatory arena. When I was in that world, it seems like we weren't incentivizing either. But I think that it's not uncommon, and I think it's a good thing. What you'll find financially is it's nice to transition that cost to collect to the front end, and in many cases, your front staff who are engaging those patients, they're on your lower end of the payroll scheme anyway. So it's nice to transition that off. Not only that, but it's beneficial to the facility to collect that up front, the cash flow that earlier than later. So the impact to your AR metrics is nice to cash flow earlier.
All right, we'll return to the presentation.
So what I included here was our October 16 payout. I mentioned before that November's is wrapped up, but I had this presentation created, and this was a fairly stellar month. It's been an increase. What I'm doing here is I'm calculating these payout numbers based on the distribution that we discussed earlier, and as you can see, it's broken out by registrar for insurance and self-pay, and then the far right-hand column is your total incentive. So we pay out $1,700, give or take, or about 13% of total collections for that month. But you see, we collected $12,000 and some change, and so we had some stellar collections, as you can see. I think it's Linda Morgan. It looks like she was incentivized a little over $650. So I think pretty impressive. And what we're seeing as I engage these registrars via my manager there is that it's really driving their desire to engage those patients, and so they're really becoming, I think, better and better and at developing their strategy personally, and really just it's empowering them to engage those patients rather than let them pass by. Next slide. Really quick look at our performance comparison. FY16 to date, I mentioned the numbers before. I'll not go into those again. Fiscal year 2017 to date, which for us is May 1st of 17 to current. Time of service collections is a percent of total net revenue. So these are ER numbers. We're almost approaching 1%. The top quartile is about 1% industry wide. Chattooga is falling behind us a little bit, and they were ahead of us earlier on. But I think that all of the aforementioned strategies are really paying out. And our average collection per ER reg has gone up as well. As mentioned before, it was basically pennies, and now we're in the dollar realm. So I think if we can get to $5 per reg, I as a director of revenue cycle are going to be satisfied, and I think we may even see it go north of that. But nonetheless, just a really quick look at where we are as an organization as it relates to that department. Now, I would want to maintain these numbers and expect an organization-wide for it to take a bit of a step back as we roll it out to other areas. But I think with the implementation of our estimator, you'll see, I'll see these numbers go up from here. But very, very positive result, I think. Just really quick look again, copay collection. This is just how many patients were engaged, and did we take a copay on? Before it was 2.5%. Now we're up to 27%. Look at best and goal, and also self-pay collections there as well. So I've set some standards and goals for us as an organization, and we're approaching those, and I'm very encouraged by those numbers, and I continue to see them on a monthly basis go up. So I think just evidence of the potential there to collect. So I wanted to give just a really quick look at some outpatient applications. Again, I know that this particular presentation was centered around the acute care world, although I think there are some elements that you can take away and maybe think about using in your practices. Some specific tools which I think are applicable in both settings. Your eligibility response is critical. Batch and real time, and I would encourage you to use the eligibility that you have to the most efficient in the most efficient way possible. So if you can use real time, do that. We use batch and real time because we all know that patients' eligibility changes on a minute by minute basis, and so any opportunity you have to look at that and capture that information and leverage that into your collection discussion, I would encourage you to do that. Policies and procedures, again, these are basically cookie cutter from what I use in the outpatient setting, so I think you'll find them applicable. Clearly, they'll need to be altered somewhat to your setting, but they're critical. You have to have policies and procedures that drive your training, that drive your position, and have to be underscored and supported by administration. We found that cash control was the utmost importance as it relates to that, so please focus on those as well. Collections, your staff needs to know what the expectation of them is. They'll need to know that you support them. They'll need training, and all of that is called out in the policies and procedures you'll create and will be used to support this particular program. Scripting. Staff should know exactly what to say and when, so you'll need to include scripting in your training, and you want to look at best practice. You want to look at what legally you should and shouldn't say, but please be sure you include that. Competencies. I didn't include that in the list, but competencies was very important for us. As you train your staff, I'm not sure I included a competency example in my documentation, but I can gladly send that. But your staff needs to know that this is the position that practice is taking, and they need to understand that their knowledge and implementation of that is critical. And so signatures of those competencies is a way to remove any ambiguity in that. Reporting. You need tools to help you track progress and allow for managing change. However you do that, and your tools should be accurate, or your reporting should be accurate and easy to use. It should statically retain values that you've used in the past to pay out, specifically if you incentivize. If not, historically it should be static so that you can track progress and make changes accordingly. I mentioned estimator. It's not as popular, I think, in the outpatient arena as it is on the acute care side of the house, but I do know that for scheduled procedures, it's not uncommon to hear practices that are using some calculator to estimate patient out-of-pocket amounts. It can either be done manually or with the consideration or implementation of a system to allow you to dynamically and electronically do that. That's going to be, for us as an organization at Union, critical for me to really drive this forward in all the other settings of care that we have here. KPI management. I can't stress benchmarking enough. You'll need to track and establish trending. Look to MGMA for that. In the ambulatory world, in the acute care world, HFMA and the Revenue Cycle Academy are good sources for it. I've mentioned a few KPIs, but certainly those aren't all that we use. I have a whole set of them for AR management, and revenue cycle management, which conversely we're always also using SciSense for. But be sure you establish KPIs and you track them accordingly. As you well know, you can't manage what you don't measure, and if you're not measuring it, you can't improve it. Industry resources, I mentioned HFMA and MGMA. Look to others, look to your peers, and be sure all of those are included in any program that you choose to implement. Strategies, incentive structure, that was critical in our success. I knew that I could just throw another set of rules out there for our registrars, some things that we as an organization or a management team want to accomplish, but it's really not real to them until I can make it, I can help them understand financially how important it is to the organization. Again, just from a morale boosting standpoint, it's been huge, and I'm glad to be able to pay that out. And I think that it's just a successful strategy that we chose to implement. It's not necessary, of course, but that's one that you can consider even in the ambulatory setting. You want to set goals as an organization. Set goals both as a facility or a practice, both set goals at the individual level as well. Visualize those goals and people's acquisition of those goals, how well they're trending and to accomplish those goals. We made it, one of our SciSense dashboards is an electronic display that we've got via a monitor hanging up in outpatient registration, and so they can see how well they're registering accurately or their throughput numbers look. So if you can make that goal visual, make it a competition. Pre-visit estimation, I mentioned the estimator. May or may not be applicable, but if you can and you do pre-reg patients, or you have procedures that are scheduled and you know which CPT code set belongs to those procedures, you know what your managed care contracts look like, you know what your eligibility response looks like, potentially you can estimate and then tee that estimate up so that the registrar just has to engage. If you're preactively or you're calling patients preemptively, that can be rolled out at that time as well. You could communicate at that time, and then the registrar has to say, hey, you remember when our financial counselor called you about your procedure or your study that you're having today? Then it's that much easier. So a strategy you can use there as well. I mentioned batch and real-time eligibility, combination of account and encounter-specific balances. We're not doing that in our ER, but quite certainly that'll be part of our program as we move forward to roll out elsewhere. Will be culmination of both balances on the account and also the encounter as estimated for the procedure in question. Or it could be if it's a drop-off lab or if it's something that a walk-in x-ray, we're still going to ask for that out-of-pocket amount for account balances as well. So that'll be rolled out, and I would think that you would want to do that as well. I know Azalea has a patient time of service collections report, which Robin has mentioned to me before, and I think that's great. That's going to tee up the copayment amounts on the account for the encounter in question, and also is going to show you your account balance, and then give an easy itemized number for your registrar to ask for. So that's a tool you can use that they have in place just today. Educate, explain, and I think you can, next slide, Rhea. Mention goals, educate, explain, and give the patient options and reasons. Payment plans, arrangements, differing payment methods you offer, any kind of discounts for prompt pay, all of those you want to be sure you're educated on, your registrars are educated on and can use as tools in their toolkit. Hopefully they can answer the question as to why we're asking for money today. It's critical for them to be able to respond in that respect on their feet. Complete documentation. You want documentation to be in the record. If it's not in the record, it wasn't said or wasn't done. So documentation is critical. I put train, educate, manage, or measure, manage, and repeat. Sort of the mantra, I think, of lean and of process improvement. Just like anything, you want to be sure you train them accordingly, you educate them with, and ensure they understand by virtue of signature of those competencies. Measure how well they're accomplishing the goal. Manage them up, and then repeat the sequence as necessary. As you move forward in all of these things, you'll see that your culture changes, and that does take time. Again, even here, we're seeing that the culture is shifting, but it's not necessarily as quick as I would like, but it does take time. It takes time to change culture, and it's not something that you can just switch overnight. So that's all I've got, Rhea. I hope that information is helpful. And I'm happy to answer any questions that you have. Whether or not I have an answer or not, that's to be determined, I suppose.
All right. Thank you, Jay. We're going to take some time and answer any questions that the audience has. So if you guys look on your GoToWebinar control panel, there is a section labeled questions, and you'll be able to submit any questions that you have for Jay. And we're going to give the attendees some time to submit their questions and to think about them. But I would like to let everyone know that if you do have questions that are a little bit more specific, or if we do run out of time, we're more than happy to follow up with you guys one-on-one after this webinar is over. So just hold on to your questions if we don't get to them. All right, Jay, so the first question that we have is, how do you go about implementing a stricter TOS collections policy if you haven't traditionally enforced one in the past?
Well, what I would say to that is through policies and procedures and also administrative support. So, you know, in the past, we have an HR policy here as it relates to discipline. We have a disciplinary process. We also have, which references policies and procedures at the organization level. So if you don't have policies and procedures, again, I highlighted those. I stressed that you want to create those, and then you want to have them execute and fill out their competencies. And so as you train, you want to be sure, just like nursing is filling out competencies with clinical understanding for procedures they do, that you're doing the same thing on the administrative side. So later, when you try and hold them accountable and you try and move forward with regard to your disciplinary procedures, if necessary, that you've got documentation there that supports the understanding that they expressed when you train them. So there's no ambiguity in that respect. And so I would just say, in that regard, focus on that in your policies and procedures for this particular initiative. Include competencies, and look at your disciplinary procedure at the organizational level to be sure that you can move forward if someone were to, not maintain their understanding of what should occur, moving forward. So obviously you want to be sure people are being turned to try and comply, but if they're not, you have to have something to stand on at an organizational level.
All right, our second question is, does Union General offer telemedicine visits to their patients, and if so, do you find that these services are harder to collect for? Yes, we do offer telemedicine patients, telemedicine visits. Right now, the scope's a bit limited. Our telemedicine right now is really with the nursing homes. We do have a telemedicine initiative with some of our indigent patients, and they're in the community that have been frequent flyers in our ER. And so what's happening is we've got EMS going out to see them, and if there's the telemedicine initiative or a visit that needs to commence, it will in that regard. So I would say it's really not lent itself yet to collections per se. We probably will expand that at some point, but it really depends on what side of the coin the patient's going to be in that telemedicine encounter that would drive how well we can collect. Some obviously where we're the originating facility and the patient is off-site, it's obviously more difficult to collect versus the patient being here and them consulting with a physician in another facility, obviously. So in those cases, it will drive. It's really not been in the scope of this thus far, but I can foresee that occurring in the future. Okay. Our next question is, what about patients who have large outstanding balances and can't pay it off in a single visit?
Well, and we've got that problem here today as well. And what I think will occur is we will give our financial counselors, which they already have, but also our registrars, the leeway to set payment arrangements for those patients with large balances, and to be able to collect accordingly at time of service. And so, I think that as we roll this out, and I'm speaking of my facility, but as we roll this out to the outpatient arena, we're going to have more situations where that's applicable. I have to understand that we're engaging them appropriately. But what I would say to that would be that you want to be sure that you've got a payment plan policy set up, and that you've got prompt pay discount policy set up, and that those are folded into any initiative that you offer as it relates to time of service. And so that's what I would hope. As it relates to our ER here, we've really just been focusing on time of service balances. We haven't included account balances thus far, but we will moving forward. Again, we're relatively young in that as well, but I would say that if you've got payment plan options in place, and you've got prompt pay discount options in place, simply include those in your time of service arrangements as well.
Okay, our next question is, should we collect at check-in or at check-out?
Well, I think that's probably your option. We all know, really the problem with, and it depends on the scope of your time of service collection initiative. If you're looking at just co-payments and account balances, potentially you could collect early on. If you're looking to factor in accrued balances based on services rendered, it would need to probably occur subsequently, unless it was for a scheduled procedure which you knew what the scope of services were prior to them incurring those. For us in the ER, it's certainly subsequent to service rendered. In an outpatient setting, I want it to be prior. Now that's going to be an outpatient thing. For inpatients and observation patients here, we're going to develop a process which would engage the financial counselor as the patients in the facility. So it would certainly be probably as they're being treated, if you will, or within the course of their stay. So I don't know if there's a right answer or wrong answer. I would say that do what's best for you and the tools that you have at your fingertips, and then manage it and measure how well you're doing. If you think you can expand it and collect prior to service being rendered, then great. It may be that you don't calculate the patient amount until the physician documents in the EMR, and you push charges from the EMR, and the charges fit the account, so you really can't engage them on any deductibles that hadn't been met necessarily, unless you know what's going to occur before. So that's what I would say in that respect.
Okay, and our last question is, what do you do when patient gets mad or upset? Is there a good talk track or an answer for handling these kind of situations?
Yes, and I think we've called that out, or at least it's in my it's in the scripting. We've trained them accordingly, and so they do know what they should and shouldn't say when the patient presents in an angry capacity. Clearly here we've given them the opportunity, because it's an emergency setting. There's no way we can force the issue and require collections per se, but we have to let them be seen and at very least receive that screening. In an outpatient setting, it's going to determine quite clearly as to whether or not it's a stat or an optional procedure. And if it's something that's not critically necessary to their health, then we can reschedule or do something different. But yeah, you want to be sure your scripts are specific to address patients that are not happy about you asking about money. What I will say here, it's been really an eye-opening. I've not had a single complaint about our collection effort in our ER, which I'm really surprised about. I thought almost quite certainly myself or the CEO would receive some complaints, but we've been surprised in that for the most part, I think intrinsically people think that if I'm receiving a service, then there's something I need to pay. And quite clearly there are those that abuse the ER and that then abuse that setting as well, but even they have that thought process. So we've not received any complaints, and so I know to answer your question, I would just be sure your scripts are built. I don't have a magic wand or say here's the single answer that I can give you for a patient that becomes irate, but there's plenty of scripts out there, and there are ways strategically and tactfully to handle those patients. I would stress having them in a private area, and so that they don't feel like they're being encroached publicly. That should minimize some of your unhappy patients. But there again, I would encourage you to move forward in that, because again, we found that patients, they want to pay, and as an organization, you have a fiduciary responsibility to allow them to pay and alleviate those up front. And again, it benefits everyone.
Thank you, Jay. That's about all the time we have for questions, but if we didn't get to any of the audience's questions, please feel free to follow up with us after the webinar. On behalf of the entire Azalea Health team, thank you so much, Jay, for participating in this and sharing all of your insight and providing all of those really useful resources, the spreadsheets and the documents and the policies and procedures that you provided. I think it'll be a really big help for our audience.
Sure.
And just to remind everyone that this webinar recording, the presentation slides, and the handouts are going to be emailed out to everyone about maybe around 3 o'clock today. And if you have any questions, feel free to follow up with us. Our email here is info@azaleahealth.com. We're happy to help in any way, and we hope you can join us for our future industry webinars. Thank you.
Thanks, Rhea.